team. We're going to do a quick intro video on the drug dosing labels that I created. So you may have seen these before. These are actually drug dosing labels. There was a prototype that was in Team 3's bank. The formatting wasn't that pretty, so this is the finalized one. These will be used as reference tools, not only reference tools to look at the dosing, but also reconstitution of the medication as well. As you know, we are reconstituting a few of our medications already, but we're looking into reconstituting more in the future. So you can use these to identify the lines, identify the bags, and also as well as looking up the dosing ranges. So we have over 20 that are included in here. They're all located on a ring binder. Of course, over time, we can consolidate this, make it smaller, make it bigger, add more drugs, whatever you guys think once we get formalized feedback. But for now, it's going to be about this size. They're all going to be kept in these small little laminated pouches. I'll show you what one of these pouches looks like. You can actually just open it up. It seals right here. Seals really nice. So if you toss this ring binder around, all these labels aren't going to be flying out of there. And you can just easily open it. Well, easily open it. I'm trying to easily open it, grab a label out, slap it on your bag. And each of the labels, as you open this up, you'll see each label is different color coding. There's kind of a thought process that goes behind the color coding system here. Black is any calcium channel blockers or any electrolytes. Yellow is kind of like the red ghost stop here, if you think about it that way. Yellow is going to be slow down. This is going to be antihypertensives. Green is going to make your blood pressure go up. All the ones that are in green are going to be vasopressors. Purple is going to be antidysrhythmics. Red's going to be stop, safety double check. These are paralytics. Blue is going to be slow, chill out patient. These are going to be pain and sedatives. And note here in the blue, it does say that for the sedatives or the pain, you have to make sure you chart a pain score with this and also RAS score in the ESO charting system. So let's go over a few drug dosing examples. Amio actually has 2 slides. So there's one here for wide complex tachycardia, the 150 milligram bolus over 10 minutes. And then also the drip. I took it out so you guys can kind of see what it looks like. And here you can see it says amiodarone infusion, what you should mix it in, 900 milligrams in 500 mLs, D5W, what it's for, which is symptomatic AFib, and then notes that are pertinent to the drug, such as this says amio use filter tubing. Another example, we can look at a little more common one, which is cardizem infusion. Here it's taken out of the clear plastic binder. You just peel it off right here, slap that right on the bag. It says what the concentration should be, 125 milligrams and 125 mLs, what the goal for the medication is to keep your heart rate lower, less than 110. And these are protocol referenced, so small notes from our protocols are included on these labels. In addition, our most favorite, probably and most common one is Levophed. Note, Levophed can be different concentrations from facility to facility. I put, it's 4 milligrams and 250. Granted, you may find the minimum concentration at other facilities to be 8 milligrams and 250. That's where it is at the current facility I work at, but each place can be a little bit different, or they can even have quadruple concentration, which is 16 milligrams and 250. So these are used as like a safety double check. Let me double check the concentration of my drip and make sure that you're charting this as well. And another note here is some facilities do go up to 30 mics, but per our protocols, if you go above 20, you have to notify the provider. So I put that note right here as just a reminder. Another common medication that we use frequently, if we scroll through this guy here, is, here's a common one that is a little bit different. It's Epi. So 2 milligrams and 250, granted, some facilities do 1 milligram and 250. Some facilities do 4 milligrams and 250, which JFL does. That's why we put on here what you should check to make sure it's at. And then the dosing range too, which is normally 1 to 10 micrograms per minute. Also, it can do mics per kilogram per minute. And what to reconstitute it in and what the goal would be. Another medication that we included in here, fentanyl, of course. This one's really common. You guys have seen this probably in transport more frequently with drips. Note, this medication is on a national shortage right now. So our protocols, we reference to make this a smaller volume, which is 50 mLs here, 250 micrograms and 50 mLs, just so we're conserving our drug as much as possible. You may be picking up the patient from JFL, and they may have a 250 ml bag. We don't want to be remaking that bag. We want to conserve our medication as much as possible. So just please note that's why we do have certain concentrations listed on these labels, is to conserve our medications. Another one to note is heparin. Heparin here, the concentration can range. I've seen heparin concentrations range from facility to facility and at the same facility before as well. These are pre-mixed bags, but note it can range from 50 to 100 units per ml. So just always double check with your partner that you're double checking what the concentration of the bag is and labeling it, just as that safety double check. We'll just go over one more on here, which will be, should we do our favorite, propofol? So propofol, as you know, it is pre-mixed, but this just has a note to titrate to your rascal and also chart that each hour. Okay, I guess one more. We'll do becaronium. This is the only paralytic that is currently listed in our labels. Thus, it is red. That will be a stop, double check. This is the drip concentration. Now, in red has our IV drip protocol. Note that according to up-to-date micromedics, you can do a minimum and maximum concentration that is listed here at the bottom. So when you get to bedside, double check, because this is a paralytic, that your patient is sedated. That's why we put RAS here. And you can also check their train of 4 if they have the device at bedside, which you probably should be doing. We do not carry this device with us because we do transport. We should just be checking it really when we get to the bedside. If the person's train of 4 is, say, like 0 out of 4 and they're only in 0.8, you're not going to put them up to 1. You're just going to keep them at the 0.8, the lower. So that's why we put that reference tool there on the bottom, just so you can double check. All right, and any questions you guys have, please email me, text me, call me, whatever you want to do. This reference tool is to make your life easier, not harder. Just wanted to make sense and make your job easier. So any ways we can improve upon this process, please let me know. And I'm looking forward to seeing you guys all soon. Thank you for everything you do. Talk soon. Thank you. You flip it. You can take it out of this little pocket here. These ones actually seal, so if you throw them around, it's not gonna, oh, it did fall out. Oops.